Here we are on our first episode of our first podcast. My name is James Green. I'm with
Parsa Mirhaji.
That's Dr. Parsa Mirhaji to you.
Everyone calls me Parsa.
It's true. Everyone does.
You better get used to that.
Yeah, it is. But still, you are Dr. Parsa Mirhaji.
Well, if you want to be accurate, I'm Doctor. MD, PhD.
He's far smarter and better educated than
and
me.
obnoxious.
And obnoxious. And interrupts me.
And interrupting.
So
Try to be precise.
we're going to, so a little bit about our backgrounds first. I'm just a business guy. I've done a bunch of startups, and Parsa found me because he wanted to take some of the technology he's built and spread it far and wide. And we have a company, Cognome, that is doing that. But this podcast is not about that. This podcast is about the genesis of AI. And I'm going to talk a little bit, Parsa, about your background, and then you're going to round it off with the things that I forget. Parsa was born in Iran. He basically, I was going to say brought the internet to Iran, but certainly brought the internet to academia in Iran.
To Tehran University of Medical Sciences, to be exact. That was the very first time that in medical school, someone thought about connecting to the rest of the world. In almost real time.
And as if that wasn't enough, he built an entire EHR that is still one of the largest EHRs in the Middle East. Is that not true?
Yes, it is. It is. It is hundreds of hospital systems and an integrated network of health systems running one operating system, which is our EMR.
And after those modest achievements, moved to the United States, University of Texas. I've heard fun stories about how that started in very modest means. How long were you at the University of Texas?
I think 10 or 11 years.
And then
11 years.
And then came to Montefiore, that must be over 10.
2012.
2012, so 12 years ago. And in that whole time has been focused on building what we think of as a learning health system. We should talk about what we're going to call the podcast. I got some names here. I had one which I liked, Parsa Parses AI. No.
Wow.
No.
We laughed about it.
Or
move
here's
on.
here's another one I liked, artificial intelligence or natural stupidity.
I'm not a believer in those zingers, by the way.
No. Well, we're going to talk about learning health systems, so maybe just learning health systems.
Yeah, I would call it that, not focused only on AI or machine learning. Let's talk about pan-informatics, right? Everything that you need to consider, and AI and machine learning is part of it, but how you translate it to practice is also a big part. How do you empower patients with it and push all of that technology to the patient's hand is also a part. Where do you bring the information and data to feed into these machinery is part of that conversation. So let's just call it pan-informatics for a learning health system.
There we go. All right, so we have a name. So now let's have a beginning. Parsa, where would you like to begin? I think we should begin the story while you were at the University of Texas. What was the first thing that you did that was the first kernel of a learning health system?
So let's roll back just a little bit before that, because I think it is relevant. So I was deeply involved in building EHR systems, right, and connecting EHR systems at the service of a healthcare system, taking care of patients, using data, and that's when I came to the United States. I was in Texas Heart Institute and University of Texas Health Science Center at Houston to basically practice cardiology. I had just arrived when 9/11 happened. And that was my background, right? Health information, connecting hospitals to each other to take care of patients, focused on how to apply data to take care of patients and hospital systems and so forth. And 9/11 happens. And overnight, I turned from a informatician to a public health informatician. I talked to my supervisor then, late Dr. Ward Cassells, who later became the Secretary of Defense Health Affairs during Bush administration. But at the time, he was a cardiologist, chief of technology transfer in medical school in Houston, about something that I was actually working on when I came to the United States. At the time, it was called RDF, and people had already just started to talk about semantic web and web of machines, and later it became the Web 3.0. How do you connect the dots across hundreds and thousands of data sets, web scale data integrations, or automated agents could navigate this space, hop from one website to another, from one database to another, gather information, assimilate information, and make an inference. There was, and Tim Berners-Lee, by the way, the same person that invented the www HTTP web concept, web for humans, was behind web of machines as well. So that was what I was working on. When I did, I will never forget this. When I first Google search for RDF, which is one of the frameworks used for semantic web, there was only 11 entries in Google.
That's not 11. The case anymore.
It's not probably 11 million websites.
I'm going to look it up. Hang on. RDF for semantic web, 1.38 million.
And it has fallen from the favor since.
Yeah.
I talked to Dr. Cassells. He talks to his people in telemedicine and advanced research center in Army. They come to Houston. We talk a little bit about the implications of using semantic web to create what we call the next generation public health preparedness platform, which was about in real time linking hospital systems to each other, doing outbreak detection, signal detection, and large scale syndromic surveillance in vast geographical areas where multiple healthcare systems were seeing different populations in different geographical locations in order to identify potential man-made disasters.
I know that health systems can be sometimes maligned for moving slowly, but between September 11th, what date did you launch this thing?
We talked about it and launched a web portal about like 5-6 days after 9/11.
Pretty fast.
Where we brought people together inside Houston community to create agreements and coalition of willing to put a surveillance network for biopreparedness, for bioterrorism preparedness in Houston. It was later called Defense of Houston website. We won a best practice for public health preparedness from Department of Health and Human Services next year, 2022, I think. So yes, we were quick to act. The day after I talked to Dr. Cassells, 2 days after we meet with Army folks that, which they told me that DARPA is also looking into utilization of semantic web for multiple of their own logistic problems. But here we're talking about public health preparedness, larger scale syndromic surveillance for population health purposes. And we built a network. Later, it became probably third largest surveillance network for biological surveillance. Obviously, we didn't have bioterrorism at the scale that we were thinking that will happen. We didn't have any of those man-made public health problems, but we had bird flu, and we had SARS, and we had several hurricanes down south. I don't know if you
Yeah.
remember Hurricane Katrina, Hurricane Rita. So the technology we built were just gradually evolved into really large scale automated data integration across health systems to tease out patterns and clusters of and associations between the health data that could be used to characterize patients and subpopulations in a timely manner. Luckily, again, these things really never were used for their intended purposes of bioterrorism, but were robust enough when CTSA was announced first time by NIH, and CTSA is one of the biggest research infrastructure grants that NIH had. So I was part of the CTSA #1 in University of Texas. And then for the second CTSA, I came to Albert Einstein College of Medicine in New York and brought all of those concepts about large-scale data integration to allow real-time integration of analysis of data to support a CTSA program in New York. Now suddenly I was clinical informatician because the population health gave rise to a vision of using distributed, heterogeneous, and expansive data sets. And the clinical informatics allowed us to translate that to, again, going back to my roots, taking care of patients, applying data not only for clinical decision support, but also here for research. I helped building one of the largest clinical data research networks in New York. It was called New York CDRN, but it is now called INSIGHT Network. I was one of the early contributors to OMOP Common Data Model. I still support OMOP extensively, both the schema as well as the vocabularies. I think it was almost around the same time that people were talking about self-driving cars.
Yeah.
AI here, AI there, but not really in healthcare system. We weren't really talking about AI in 2015, 2016, but we had a NIH grant with one of my collaborators. Kudos to Dr. Michelle Gong. We got a clinical trial for 5 years to look into application of machine learning in predicting respiratory failure up to 48 hours in advance. We spent 2 years to build the model, validate it, retrospectively validate it, prospectively parallel to the clinical systems without really injecting those analytics into
And what was it the model?
TK.
And what was it the model did exactly?
Model predicted two things: whether or not patient will have respiratory failure in the next 48 hours, and whether or not patient would die in hospital in an inpatient setting a few days, 3 days in advance of the terminal event. We went live with our first machine learning algorithm January 19, 2017.
So
Again,
that's quite a thing, because you're now talking about a model that predicts respiratory failure in 2017. There was a need for such a thing coming in 2020.
yeah, serendipity, right?
Yeah.
We had almost everything ready. We were not knowingly, we were building everything that we needed to build for anticipation of who is going to need mechanical ventilation, because we had a model for it, who is going to die inside the hospital. We had just finished building a different machine learning algorithm for ARDS, acute respiratory distress syndrome, which is probably what kills patients that have respiratory failure inside the ICU. We had integrated our platform across the hospital system. So it wasn't running in my, it wasn't a toy model running in my laptop or in my server. It was running across the hospital system, connected to our Epic EMR everywhere. Obviously, when pandemic happened, we were as surprised and caught off guard and unprepared as everybody else. But we also had infrastructure that we could really quickly bring on board and use it.
This is a very loaded question, but how many lives do you think were saved because you had this model?
I'm not going to answer that question because care provisioning is a multi-team.
Yeah.
It's much bigger than an algorithm, much bigger than a model. You are a cog in a much bigger machine, and I don't want to steal the attention away from our clinicians and nurses and doctors that were in the forefront. I'm just happy that we were part of the solution. But we were part of the solution a few days after everybody got together, and we weren't a latecomer. I think that's what matters. When you build a model to predict respiratory failure in 18 hours or 48 hours or 24 hours, it tells you that you're not anticipating a rapid deterioration like in minutes. It is something that you're expecting to happen over hours. But in COVID, we were seeing patients that were just deteriorating in 20 minutes, in just 2 hours from their admission. So we needed to fine-tune our algorithm to do this. For COVID, with the recognition of specific characteristics that COVID had. So we worked with Intel to adopt the federated learning to connect to other hospital systems, other data sets, which worked fantastically. And we could, in 4 to 6 weeks, fine-tune our model and basically build not only models that were much more accurate on detecting respiratory failure and ARDS in COVID cases, but also do projections 2 or 3 weeks in advance on how many patients will be hospitalized or admitted to the hospital in any of our facilities. So we were providing the backbone of information for our care coordinators and clinicians to take care of patients. So we emerged from pandemic with a lot of understanding of how these systems work, how these systems interact with delivery systems, how they scale, and how they become part of the bigger machinery of health system. Learning from every patient that we have seen, not only in our own healthcare system, but in neighborhoods, in other locations, and how we can do this learning in rapid cycle, which is essentially the definition of learning health system.
There you go.
And that is why I think we are focused now on that, how you bring about everything that you have, your data assets, your analytic assets, your computational assets, your EMR to become part of a learning system that cycles through outcomes as a feedback and continuously improves.
So, just to summarize what we've covered so far today, 9/11 helped us have this concept of gathering data from multiple places.
Yeah, it was the kick that pushed us to the frying pan of thinking seriously.
But then
ultra large scale,
right?
Yeah, ultra large scale. I think that's what happened, right?
Yeah.
It wasn't a project anymore, or a academic curiosity anymore. It was an existential problem that needed to be solved, and we took our time to solve it. But I can tell you that we have a solution.
Yeah. And then once you have all of that data in place, of course, the logical thing is then to use it for predictive models. So you started building predictive models. We had a pandemic came along. And look, we already had the foundations in place to make this happen.
Foundations for learning health system should be planted across collaborating health systems. No health system will have all of the data and all of the kinds of patients that they need to really solve complex problems or rare problems or build generalized solution. What we emerged, I would say, with all of what we have done in the past decade is foundations for a federated learning health system augmented by machine learning and advanced analytics. And that's why I call it pan-informatics, because we really build everything from data to collaboration and federation and AI into a learning health system or definition of a learning health system.
So, Parsa, what should we talk about next episode?
You tell me. You can talk about some specifics or examples.
Let's
We
do
can
that.
talk
Let's dig
about,
into some
yeah,
specific examples next
yeah.
episode about some of the ways.
And maybe some of the, we went through a journey, and I don't think that we should expect that other health systems should also go through the same torturous
We would like to help
path
them a
we
little
went
bit.
for the first
Yeah.
time. Yeah, so we may want to also talk about an incremental roadmap of how you can benefit from existing experiences and infrastructure and research that we've done that may translate to other health systems and so forth. So we can talk about the maturity model.
Perfect.
You tell me.
Okay.
Okay.
Parsa, thank you very much. Until next
Thank
week.
you. Thank you for allowing me to interrupt you.
You do all the talking, Parsa. You know you do.
Okay.
All right. Thank you.